So I want to tell you about monofixation syndrome, but not from a pediatric ophthalmology standpoint, because I'm not a pediatric ophthalmologist. The reason I'm telling you about this is because you need to know it as a neuro-ophthalmologist or a general ophthalmologist, because sometimes this presents to neuro-ophthalmology or can mimic neuro-ophthalmology. And it's what it sounds like. It's a monofixator. And what that means is they're only fixating with one eye. So this is a monofixation syndrome. And although there are a number of different ways you can get to this monofixation syndrome, the one we're going to talk about today is that they had some sort of childhood strabismus, usually infantile esotropia. Then they had surgery or treatment, and it straightened their eye out, but they were left with a small angle deviation. So that small angle deviation is usually 10 prism diopters or less. And they have a facultative monocular suppression scotoma. And so you need to know about this. So it's a facultative, which means it's only present under binocular viewing conditions. Monocularly, they can see. And often they're 20/25 or 20/30 because they have a mild amblyopia, but not a very severe amblyopia. And it's central because what they're suppressing is their fovea. And it's suppression rather than ignoring the image, because it's occurring at the cortical level. So this is a cortical-based suppression that is occurring only under binocular conditions, which is why it's facultative, and it's only suppressing the center, the fovea, but not the parafoveal, which is super important. And the reason that's important is what this produces for neuro-op is we still have a parafoveal 20/30 acuity, and they have some subnormal degree of stereopsis, which means they don't have no stereo vision. They have subnormal. They have some stereo because this parafoveal has a broad disparity for fusion that allows it to fuse. And that is amazing. And so the way this comes to me is a patient is complaining that their eye is crossed. They had a past ocular history of childhood esotropia. They had a surgery, but they were left with a deviation, and they're worried about the cosmetic appearance. Oh, it looks crossed, and they have these photographs that show it's crossed. And if they don't have diplopia, that's because they have the suppression. And so probably we're not going to be wanting to do anything about this. The other way it comes to me is that they do have diplopia, which means something moved that person outside of their facultative suppression scotoma. So once you're outside of the scotoma, which is very small, it's only going to be, it can only tolerate a small degree, maybe 3 to 4 degrees of separation. If it's a big deviation, you'll get amblyopia. So if you have 30 prism diopter esotropia, the brain will just turn off the image. And if they just have a crossed eye and no diplopia, you probably should leave that alone. So that's how it comes to neuro-op. The other way it comes to me, as I mentioned, is they break the fusion or they're outside of the suppression scotoma, and the treatment is put them back the way they were. So you need to know a little bit about the monofixation syndrome. It is a monofixator. The monofixator can break down in adulthood, even though it's a childhood thing. This facultative central suppression scotoma can be generated under binocular conditions and then turned off under monocular conditions because it's a real-time change in their occipital cortex at a metabolic level. There's no structural change. It's just metabolism. And the really important thing is the way to detect the facultative suppression scotoma is letting your peds ophthalmology person or orthoptist do the Bagolini lens or the Worth 4 dot test to detect the suppression scotoma. So with the Bagolini lens, as you know, you got one eye that can see this part of the cross and the other like that. And when they fuse the two eyes together, that's the image that they should see. However, when we have the facultative suppression scotoma, one of the eyes is suppressing that central bit. That is a facultative suppression scotoma under binocular viewing conditions. And the same thing can be seen on the Worth 4 dot test. That is beyond the level of this video. What you need to know about is sometimes broken down monofixators end up in neuro-op.